My name is Dr. Jennifer Taylor-Kauser. I am the co-director of the Adult CF program and director of the Therapeutics Development Center at National Jewish Health. Now we're going to switch to talking about identifying patients with missed diagnosis. But let's take a close look at the age of diagnosis of people with CF. This data is from the U.S. CF Patient Registry. On the y-axis is the number of individuals, and on the x-axis is age, either in months or years. You can see that the majority of people are diagnosed in infancy. In fact, 60% of new diagnoses occur by newborn screen, and the median age at diagnosis is approximately 3 months. But if you follow the graph out to the right, you can see that there are some individuals who are diagnosed even over the age of 40. You also heard from Sarah about the different variants that occur in people with cystic fibrosis. Some of those variants cause no protein to be made and no transport of chloride. Other mutations allow for some residual function of the chloride channel. In this graph, on the y-axis, we're looking at CFTR function, and on the x-axis is clinical phenotype. So when you have 100% CFTR function, as in a normal person, you see that there is no sign or symptom of cystic fibrosis. On the other hand, as your CFTR function decreases, you have more and more symptoms of the disease. So by the time you have almost no CFTR function, you see what we typically think of in people with cystic fibrosis, both lung disease and pancreatic disease. So when you think about those people who are diagnosed in childhood, they not only have things like chronic sinusitis and chronic infection in their airways, they also have pancreatic insufficiency leading to malabsorption and the need to take replacement for their pancreatic dysfunction. However, those people who are diagnosed with adults often have residual function variants or mutations, allowing them to have some chloride transport and thus pancreatic sufficiency. Now let's take a moment to hear from Mr. Wright about the signs and symptoms he was experiencing, and also his experience of finally getting a diagnosis of cystic fibrosis.
I remember as a kid just really having really bad digestive problems. I stayed in the hospital because of the severe abdominal pain. Every now and they come back, but as a kid, I was having them quite often, every day, just pain in my abdominal. Maybe 2 or 3 times a month, I would come down with pneumonia, sinusitis, really, really bad migraine headaches, nosebleeds, fungus all in my nose, just a very foul-smelling scent coming out of my nose. I remember many times, was a big runner, even though I had cystic fibrosis. I was very active. I was a big runner. I used to run all the time. I used to wonder, why did I have all these big grains of salt all on my body after I get through running? A 5K race, a 10K race, a half a mile race. I constantly had the pancreatitis, and they would just constantly hospitalize me with this severe abdominal pains. My amylase level was very high. I constantly heard that. You think those would have been some signs, some signals that something is going on with your pancreas, or something about your amylase level that was very high, it was elevated. I was dealing with that, dealing with not being able to breathe. A lot of times it would just be very hurtful and tiring just to walk up a flight of stairs. I would just be out of breath, gasping for air. Even the infertility, trying to have children. I used to wonder, been married 23 years and why I don't have any children. Come to find out, since the diagnosis, that's part of some of the disease. One of my main doctors here in the CF clinic, and they sent me to the Children's Hospital to do a chloride test. That's where they take like a little plastic little deal and kind of adhere it to your skin and have you kind of walk around for about an hour or sit for an hour. And they take it and do a test on the sweat. That's called a chloride test. And they figure out whether or not you have cystic fibrosis or not. So I came back positive. And what's so funny about that, actually, I came back positive, and they really didn't believe that, I guess, me being a Black man could really have cystic fibrosis. So they said, okay, let's do another test. So I ended up doing that same test again, came back positive again. John Hopkins, because they sent the test off to John Hopkins, and that was just unbelievable. So they went ahead and diagnosed me with cystic fibrosis, even though all the signs was there all the time with cystic fibrosis.
In her seminal paper, Dorothy Anderson, who was the very first person to describe cystic fibrosis as a clinical entity, she noted that people in her case series actually included a child who was Black and a child who was Hispanic. And in fact, she said the racial and geographic distribution of the disease was wide. However, those individuals were invisible to those who wrote the textbooks about cystic fibrosis. In fact, until recently, if you read an article or a chapter, you would most often read, cystic fibrosis is the most common lethal genetic disease in the Caucasian population. While it is true that CF is more common in those of European ancestry, it is not exclusive to those individuals. So for this discussion, it's critically important to understand that race and ethnicity are social and politically defined categories without biological basis. Dr. Svante Pablo, director of the Max Planck Institute for Evolutionary Anthropology, said that even between Africa and Europe, there is not a single absolute genetic difference, meaning no single variant where all Africans have one variant and all Europeans another one, even when recent migration is disregarded. Dr. Michael Udell, professor of public health at Drexel University, said, if you make clinical predictions based on somebody's race, you're going to be wrong a good chunk of the time. For example, in cystic fibrosis, which is underdiagnosed in people of African ancestry because it is thought of as a white disease. Because CF was long believed only to occur in people who are white, the awareness and building of infrastructure to diagnose CF is absent in many places around the world. Thus, the existence of CF in countries in Southeast Asia, Central and South America, and Africa has only relatively recently been described. There are many countries in which the incidence is still completely unknown, as you can see on this map. Based on available data, mostly from established registries in high-income countries, it is estimated that there are more than 160,000 people with CF worldwide. Now, focusing more on the U.S., this again is based on data from the U.S. CF Patient Registry. You can see that, as one might expect, the majority of people with CF in the U.S. Patient Registry are white, but there are also significant percentages of people who are Hispanic, Black or African American, or other races. And if you consider, again, based on the U.S. CF Patient Registry, the various mutations or variants in the U.S. CF population, you can see them on the table here. At this point, there are more than 2,000 variants in the CFTR gene that have been described. F508del is the most common mutation in those of European ancestry, and only 5 other variants occur in more than 2% of individuals, so most of them are rare. In this table, I've highlighted for you those variants that are more common in those who are Hispanic in blue, and those who are Black or African American in red. But you'll note that if you only look for a 25 variant panel, you'll miss many, many people. And that's really demonstrated here in this slide from a paper by Dr. McCauley, where she was looking at all the states in the U.S. and asked, what if you use a panel that includes 139 variants instead of just 25? You can see on the far right in Maine, that works quite well, and you'll get most people diagnosed. However, if you look at a state like Hawaii, where the genetic ancestry is much more mixed, you'll miss a lot of people with newborn screening, even if you use a 139 variant panel. So again, looking at data from Dr. McCauley's paper, it's really important to realize that there are racial and ethnic differences in newborn screening and resultant delayed diagnoses. So on the very left-hand column of this table, you'll see race and ethnicity, and then the numbers based on the whole population of people in the CF patient registry, and those who have false negative newborn screens, highlighted in purple here, those who have a false negative newborn screen and who are diagnosed at greater than 180 days, so older than the median diagnosis. So really what we understand is that commonly used newborn screening panels will miss rare variants that are common in Black, Indigenous, and people of color with CF. In fact, one recent survey found that over half of State Department Health websites in the U.S. refer to CF as a Caucasian disease. In another paper, Dr. McCauley and colleagues showed that Black, Indigenous, and people of color infants had their first CF center evaluation, sweat test, or an encounter or care episode on average 9 days later than non-Hispanic white infants. So even when they had a positive newborn screen, they still got referred to the CF center even later. What about adults that are diagnosed? Adults often present to physicians with sinus and pulmonary symptoms. They have varied gastrointestinal involvement, so often a functioning pancreas, and sometimes have recurrent pancreatitis. Very often, they have less common variants and an indeterminate sweat chloride, so one in the range of 40 to 60 millimoles per liter instead of greater than 60 millimoles per liter. It's also really critical to think about the fact that CF is unlikely to be considered in people who are not white. So we talked about newborn screening, but there is one other test that we can do and will often do in adults when there's a question about their diagnosis, and it's called nasal potential difference measurement. In this test, we put a small catheter in the nose and then stimulate the channels that are in the nose with various medications. The normal response to these medications is shown in black. In the case of cystic fibrosis, you start out with hyperpolarization, so the red line is actually higher, and then you can see that there isn't a response to all of the different medications that are administered. Again, this test is used in cases where we're having a really hard time deciding whether or not someone meets the criteria for cystic fibrosis. And it's only offered at a few research centers around the country. After CF centers were established, so you had multiple different people making an effort to improve the lives of people with CF, they really focused on 3 pillars of treatment for people with CF. The first being repleting and maintaining adequate nutrition through use of pancreatic enzyme replacement therapy and vitamin supplementation for fat-soluble vitamins. Also, to clear that thick, sticky mucus that's in the airways, you had to use various hand manipulations or various equipment to promote mucus clearance. And finally, we wanted to control the respiratory tract infection that leads to that vicious cycle of infection, inflammation, and airway wall destruction. And those really were the treatments we used for many, many years with cystic fibrosis. But in 2019, life-changing medications were approved for people with cystic fibrosis. These drugs not only improved people's lung function dramatically, but also improved their weight, their body mass index, their CFTR function as measured by sweat chloride, and critically importantly, their quality of life, and their rate of pulmonary exacerbations. Initially, these drugs were only approved for people who had a copy of F508del and only for those people who were older than age 12. At this point, that label has been expanded to include children down to the age of 2 and people who have other variants that are similar in those dysfunctions that already were approved. So really a lot of people in the United States, the majority of people are eligible for these life-changing medications. Now, if you think about access to therapy, it's very different for people of color. Shriver and colleagues actually looked at ethnic ancestry and the number of copies of F508del that people had. That's important because the very first approval for these new life-changing medications that we'll talk about shortly actually was based on the fact that you had an F508del variant. So if you look in people who are white, about 10% of people don't have a copy of F508del. But if you look in people who are Hispanic, Black, Asian, and Native American, it's much less likely that they were going to have an F508del, which would have made them eligible for this therapy. And in fact, if you look in the US CF patient registry, it's much less likely that people who are Hispanic or Black actually are prescribed these medications because they don't have the variants that make them eligible. So Black, Indigenous, and people of color who are likely to be diagnosed late, as we've already discussed, are also less likely to be eligible for these life-changing medications. With the use of these medications, even in those who had very, very low lung function to start, many of them improved their lung function enough so they could come off the lung transplantation list. However, for those people who had very low lung function, use of those modulators actually was quite effective, and most of them have come off the lung transplantation list. However, there are some people who can't take the medication because of side effects or who don't qualify for the medication. For those people, we still consider lung transplantation. We really start to think about lung transplant when people have very low lung function and or are rapidly declining, or if they have a low lung function and markers of shortened survival, such as a very low 6-minute walk distance, hypoxemia at rest or with exertion, hypercarbia, or pulmonary hypertension. Other things we think about are people who have frequent exacerbations or ICU admissions, massive hemoptysis, or pneumothorax.